Good afternoon and welcome to OCTalk, the show dedicated to helping home health and hospice providers run compliant and successful agencies. OCTalk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're talking about value-based purchasing. And now I'd like to introduce our industry guests for this episode. We have Sherri Parson, RN, HCS-D, HCS-O, HCS-H, COS-C, OC Advisory Board Member and CEO for Infusion Health on the call today. And we also have Lisa McClammy, BSN, RN, COS-C, HCS-D, HCS-O, OC Advisory Board Member, and Senior Clinical Education Consultant with MAC Legacy on the call. Thanks so much for joining us today, Sherri and Lisa.
Thanks for having us.
All right, let's get the discussion started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane, and we'll try to get to as many of those as we can. And I know we've got a lot of slides to run through today, so Sherri, I'm going to turn things over to you, and I'll just advance the slides as you need.
Okay, you can go ahead. There you go. Thanks, Jan, and thanks everyone for joining us today. And as we talk about value-based purchasing, Lisa and I, again, as Jan said, we have a lot of territory to cover, but Lisa and I thought it would be beneficial to start with a high level, kind of basic, set the table, if you will, so that we're all on the same page as we dig in a little bit deeper. Now, it might at first seem that this quote has nothing to do with value-based purchasing, but indeed it does. To improve is to change, to be perfect is to change often, Winston Churchill. Now, we have seen our share of changes already with value-based purchasing, and it's really easy to get discouraged as we have to adapt to these changes. But just like we have those quality improvement programs in our organization, the more we change and improve upon those deficiencies, the closer to perfect we get. Never quite get there, but the idea is to continually change. And of course, when we improve in value-based purchasing, there is some rewards. Next slide, Jan. Let's start by reviewing the goals of value-based purchasing. Improving the quality and efficiency of home health across the nation by eliminating inadequate and uncoordinated care. So we want to utilize the resources of Medicare, our organizations, but we want to coordinate that care between care settings. If you look at adverse outcomes and events, you can trace them back when we change healthcare providers or healthcare settings. So we want to do better with that. We want to improve that patient experience with their care. And long before we got value-based purchasing, National Academy of Science and Engineering did a study on value-based purchasing a couple times. And one of the things that they found were those social determinants of health and getting that buy-in from our patients. Patients have to understand their care. They have to be able to get to their therapy and have their therapy. So that's going to be a buy-in by that patient to get those better outcomes. One of the other things the study showed was that when we start with these deficiencies in function, the more deficient somebody is in their functional status, the poorer the outcomes are on the other side. So finding ways to strengthen that physical function is going to be important also for those outcomes. And then addressing health issues in our current setting so that they don't go to the emergency, they don't go to the hospital. Not only is that very costly, but our patients usually have setbacks, right? Clinically, they sit in a bed, they get weaker, and of course, that's going to also decrease the good outcomes that we're hoping to get. Next slide, Jan. So what changes do we have in store for 2025 with value-based purchasing? There's been quite a lot of measures removed, others added. Some existing measures have different weights now, and then we're going to update that baseline year again. Next slide, Jan. These are the items that make up the scores in value-based purchasing. And if you're a large cohort, you'll have 35% of your score that will come from OASIS. That'll include improvement in dyspnea, improvement in the management of oral meds, and DC function. And you'll get another 35% if you're a large cohort for the claims portion. This will include the PPH and then the discharge to community, but the claims-based version of that. And then finally, you'll get 30% from your HHCAP survey scores. And so if you're a large cohort, 35 plus 35 plus 30 equals your 100%. So if you are a small cohort, the reason you're a small cohort is because you didn't have enough of those HHCAP surveys. So that's not going to be part of your calculation. You're going to get 50% from the OASIS and 50% from claims. Next slide, please. Now let's drill down a little on the weighting changes in 2025. There's a lot of data here for your reference, but we're really going to just narrow in on improvement of dyspnea. It's currently at 5.83% for a large cohort, and that's going to increase slightly to 6%. Small cohort is going to change from 8.33 to a smidge higher, 8.57 in 2025. Improvement in management of oral meds. You're going to move from 5.83 for a large cohort to 9% in 2025. Small cohort, you can see there 8.33 to 12.86. Now that new DC function score is going to make 20% of that large cohort compared to the cumulative score of 17.5 for the TNC measures. And for the small cohort, it's going to be 28.57. And again, when we look at the TNC cumulative, that was 25%. Now we're not comparing apples and apples when we're looking at TNC and DC function, as you'll see in a little bit, but just to give you an idea of the weighting. Next slide, please. So drilling down with the claims-based measures, the new potential preventable hospitalization measure is 26% for that large cohort compared to the cumulative acute care hospitalization and emergency department use of 35%. Now, incidentally, it is now that PPH measure is going to include those observation stays, and Lisa will give us a little bit more about that later on. So then again, when we look at the small cohort, 50% is that ACH and ED use, and that's going to break down to 37.14 for the PPH and 12.86 for that discharge to community measure. Next slide, please. So I'm a very visual person and really like illustrations and simplifications. So for those of you that are here that are like me, here are the OASIS changes for 2025 at a glance. We are going to keep that improvement in dyspnea, but we're going to have a slightly higher weight. We're going to keep the improvement in management of oral meds, and we're going to increase the weight in 2025. We're going to say goodbye to the TNC self-care, TNC mobility, and replace those with the DC function score. And then finally, the discharge to community OASIS-based measure is done away with, and instead it's replaced with a discharge to community claims-based version. Next slide, please. So this is an illustration of the components of the DC function score with a little color coding, because again, I like to have my visual cues here. Now, what you're going to notice is we're not using those 1800s anymore, but we now are going to move to the GG. But where we have the TNC self-care, we're going to replace those with these GG self-care items, the 130s. Not going to take time to read those. Those are the aqua color there. The light blue color is your mobility. So these are your mobility GG items, and again, coincides with the TNC mobility, right? We have some similarities there. And then what I want you to really pay attention to is the OR here. We are only going to use either the 170J or the 170R, depending on whether your patient is ambulatory or not both. Next slide, please. So here is one more of my simplification illustrations. This one is for the claims-based measures for 2025. Really a complete overhaul. Neither of the current measures are going to move forward, but both are going to be replaced by that potentially preventable hospitalization, that PPH measure, and then additionally that discharge to community, the claims-based version. And then HHCAPs, there's not going to be any changing in the scores with that, but remember that's only going to be applicable to that large cohort. Next slide, please. So with potentially preventable hospitalization at PPH measure, the thought is that certain conditions could be avoided if they were managed correctly. So this measure is really looking specifically at 4 areas: inadequate management of chronic conditions, infections, injury prevention, and then also inadequate management of other unplanned events. Next slide, please. So as organizations, we need to begin to assess what we're doing, and we really need to understand the OASIS-based measures. Now, Jan, there's a little animation, so if you click again, we should highlight what it is we're really looking at here. Yes, so we're really looking at the patient's observed score. So whether or not it meets or exceeds what was expected. So how do we know what was expected? You see there, we've got a formula for that, a risk-adjusted formula that lets us know what was expected with that patient. So if we have patients observed to meet or exceed, we're going to divide that by all of the episodes that are applicable. However, not all are applicable. So you're going to see at the bottom of the slide, you have some exclusions there. So for example, an unexpected inpatient facility transfer, death, discharge to hospice, patients under 18, episodes less than 3 days, patients in a coma or vegetative state, those are going to be excluded and not part of that calculation. Next slide, please. We're going to look at that PPH measure. And Jan, again, if you can click again, we'll get a little highlight there. What we're really looking at is, yes, thank you, the rate of risk adjustment, PPH, including observation stays divided by all the eligible episodes for the agency. So again, when I say that, you see we've got some exclusions there on the bottom. LUPAs. If your patient received care from multiple home care agencies, they're not going to be counted in this. Let's say they didn't have Medicare the entire 12 months prior. Again, they're not going to be part of this calculation. They'll be excluded. Next slide, please. All right, so we're going to talk about the claims-based scoring assessment. And again, if you want to click there and give me my little highlight there, what we're really looking at is that the patient had no unplanned hospitalizations or death in the 31 days following discharge from home health. And again, we're going to take those that met that criteria and we're going to divide them by all of the applicable episodes. There are a lot of exclusions here. I'm not going to take time to read all of the exclusions here, but I do want to answer one question that I get a lot, is what about my hospice patients? If we discharge to hospice, are we going to get dinged on this? And you can see there that no, you're not. Hospice, if they're discharged to either home hospice or facility hospice, they are not included in this calculation, so no worries there. So I'm hoping I left enough time for Lisa to dig in deeper here, so I'm going to hand it over to Lisa.
Thanks so much, Sherri. Yeah, you've left plenty of time. We're good. So I won't spend a whole lot of time here on the reporting because we're really kind of talking about the changes, but I want you to be aware that it's extremely important that you keep up with your reports. If this screenshot right here with your care points is not familiar to you, you need to be looking in IKEYS and getting these reports and looking at them and see where you stand. I think if you click, Jan, you're going to get me a little box maybe. Yeah. So I won't spend, again, a lot of time here, but what I want you to notice is when you're talking about your care points, you have achievement points and improvement points. So your achievement points are what points did I get up to 10 that compared to everybody else in the country. Your improvement points, on the other hand, are how did you compare against yourself? So whichever is the higher of those 2 points is what you get for value-based purchasing. So you'll notice in that third column there, your home health agency's care points is the higher of the 2 columns that are in the red box. What I'm just going to briefly talk about this particular one. You notice the percentile ranking in that last column. This agency was greater than or equal to 75th percentile on every single measure, including those that are rated, weighted higher, in the claims and the OASIS. When you're talking about HCAHPS, this agency actually got 0 points in HCAHPS. So they were in the less than 25th percentile. Next slide. You will also notice that this agency got a positive increase in payment this year of 4.551%. Extremely good. That's one of the extremes that CMS was predicting, that you would not have very many of the extremes. Most people are going to fall in the plus or minus 1.5–2%. This one was weighted or fared extremely well based on those weighted items and how well they did in them. So just know that you want to, obviously do well on everything and concentrate on everything, but you want to make sure that you're looking very, very heavily at those items that are weighted the most, your hospitalizations, your functionals, whether you're talking about the TNC measures right now, or whether you're talking about the DC function score starting in 2025. I won't spend a lot of time here. This is the whole calculation of how they come up with that payment adjustment based on, you see the first column in that top screenshot is your actual total performance score. And then, there's again calculations to get to the point of the final TPS adjusted payment. So I won't spend a lot of time there. You have this for your reference. Next slide. Oh, sorry, I should have had you click on that. Okay, go ahead to the next slide. Sorry. There we go. What I want you to get from this slide right here is, as far as your total performance score tracking, it's really important that you track your total performance score over time, just so you can watch, the numbers, and they're going to move. If you'll click one time, Jan, I think we're going to get an arrow here. You'll notice that, progressively, the 25th percentile has gotten higher and higher and higher. As a general rule, it did drop back off in July of 2024, but for the most part, it went higher, 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 and so did the 50th and the 75th percentile rankings, and then that 99th percentile ranking also. So again, watching that trend over time as people get better, agencies get better and better and better at those measures, that percentile ranking to achieve that 75th percentile or that 50th percentile is going to continue to get higher and higher. Okay. Like I say, if you have any questions about that, I'd be happy to answer them, but this is more for your reference than anything. Okay, Jan, let's go to the next one. So let's talk about what are the quality strategy goals. We want safer care. We want to reduce harm to our patients. We want them to get, functionally stronger. We want them to not go into the hospital. We want to make sure that they're, not falling, for instance. That's just one, for instance, reducing that harm. We want to promote effective communication and coordination of care. And that is not only with your patients, your families, but with other staff members within your agency. Make sure you're having that good coordination of care with the providers. The patient may have multiples. We want to promote that. Effective prevention and treatment of chronic diseases. Our patients come to us with multiple diagnoses as a general rule, and they all have to be managed. If you're not managing those chronic conditions and, having that patient, they may not improve as far as their diagnosis is not going to go away necessarily, but how are we managing that? How are we keeping our patients at home? How are we keeping them out of the emergency department? How are we keeping them out of the hospital? Involving patients and families and partners as partners. We talked about that in the coordination just a second ago. Have your family take some ownership in how are we going to keep this patient at home and how are we going to keep them safe, and try to involve as many patients, families, caregivers as we can as partners for this patient to remain in their home and be safe. Working with the communities to promote healthy living. I mean, that's general. If your agency, does flu shot clinics, or if they do, whatever within the community to, enhance safety at home, not necessarily just for your patients, but as a general, safety, promoting that healthy living within the community. And then, of course, making care affordable. We're always, CMS is always looking to save that money and, protect the Medicare funds. So we want to make care affordable. Next slide. So the model baseline year, as of right now, is 2022. So we're in performance year 2. We talk about years, models, performance, baselines, all of the different years, but our performance year that we're in right now is 2024. And the baseline for that is 2022. Starting next year, so starting with our performance year 2025, we're going to move that baseline year to 2023. So basically, if you're looking at your reports, your report that you got that tallies up all of your 2023 data, that's what you're going to be compared against starting in 2025. So the reason for that is because of the addition, replacement of items, that had to be updated in order to have that data and be able to compare. So they had to move that up to 2023 as the baseline year. One exception to that, your claims-based discharge to the community, it's going to be a 2-year baseline rather than a single year. Everything else is a single year. So for that one measure, it'll be calendar year 2022 and 2023 as your baseline. All your achievement thresholds, your benchmarks, all of that are going to be updated to the 2023 model baseline year, and that was in your interim performance report for 2024, and then it's in your annual performance report that came out last month. Next slide. So when you're talking about that home health within potentially preventable hospitalization measure, there was a MedPAC study that estimated that 17 to 20% of Medicare beneficiaries that were discharged from the hospital were readmitted within 30 days, and 76% of those were potentially avoidable. It cost $12 billion associated with those potentially avoidable rehospitalizations or hospitalizations. The potentially preventable hospitalization measure already in the quality world has replaced the acute care hospitalization and ED measure. So, this is just going to have value-based purchasing align with the home health quality reporting program when switching to that potentially preventable hospitalization measure. Next slide. So hospitalizations are still what you need to be concentrating on, one of the major things you need to be concentrating on. Also remember that with that PPH measure, you're also going to be looking at observation stays, and you're going to be looking at emergency department visits. So you have to consider all of it. So, we said, oh, we took away these 2 measures and added 1. Well, we really didn't. We really took away those 2 measures, and 1 measure includes them both. And then we brought the claims-based discharge to community. We brought it in the claims area. So again, can concentrate on right now, why are your patients going into the hospital? Was it preventable? Everybody, patients, families, your staff, the provider, everybody needs to be a partner in keeping this patient out of the hospital. It is required that you put your hospitalization and ED use risk and how you're going to address that risk in your plan of care. If you're not doing that, you need to be. It's required by the conditions of participation, and you want to make sure that you're doing that and make it practical. Make it something that it's applicable to your patient. I mean, some of the things are fairly generic, but not all of them. Your patient may have very specific needs that need to be addressed to keep that patient out of the hospital and the emergency department. If you're not already doing this, I would highly suggest that you look at every single hospitalization, observation stay, and emergency department use. Ask at every visit, have you been in the emergency department? Have you been in the hospital? Because we all know how it happens. Somebody goes in for a visit and they go, oh yeah, I was in the hospital last week, last weekend, I got home yesterday, or whatever. It happens. So you want to make sure that you're, first of all, teaching your patients to let you know before they go if it's not, a true emergency. So hopefully you can intervene and keep them out of the hospital if possible. but also you want to make sure that they know that you're asking so that you know when they go in, and then you want to scrutinize to find out, was there something we could have done to prevent that? Use any technology you have available to you as far as keeping that patient out of the hospital. If you're doing, you know, any kind of telemonitoring, or even if you're just doing phone calls, whatever it is, anything you can do to, and we'll talk a little bit more about this in a couple of slides, but anything you can do to keep that patient out of the hospital. Next slide. So when you're talking about unplanned hospitalizations and EDUs, again, that needs to be one of your highest priorities. Patient-focused approach, what are the risks? When you do your assessment and you get ready to leave that home, if you're thinking in your head, oh man, this patient's gonna be in the hospital next week or tomorrow or whatever, figure out what you can do to prevent that if at all possible, because you do not want that to happen. But sometimes we have that gut feeling. So what are we doing to prevent that? What's your plan? Again, that should be on your plan of care, but you know, make sure your plan is individualized. What can every member of the team, including the caregiver, including the family, including the provider, plus your team, what can you do to prevent the hospitalizations? Make it an initiative within your agency to get your hospitalization ED use, observation use down. You know, whatever it is you need to do within your agency. You know, your patients don't want to bother you, so they don't want to call you before they go. Tell them to bother you. They're not bothering you. That's what you're there for. You're there to take care of those patients. So another thing is potentially maybe some tuck-in calls, maybe some Friday afternoon calls, because a lot of hospitalizations and EDUs happen over the weekend. You know, focus, have a plan, reevaluate that plan, make everybody accountable to that plan. You know, we all know how to do plan, do, study, act, and reevaluate, and you know, add different interventions if we need to. You also want to track and trend your reports and make it part of your QAPI. You should be making that part of your reporting on your QAPI, but make it part of how you're preventing those hospitalizations. Make it a part of your QAPI. Next slide. So when you're talking about, we'll switch gears here to the discharge function score. If you haven't already started education on GG items, you should be. It's really all of them, but of course the 10, 11, 10, and one of the two, walking or wheeling item. Make sure you're focusing on those. Make sure everybody understands that they don't directly align with the M1800 questions, but you also have to look, they have to look like the same patient. So you want to make sure that everybody understands the intent of the question, and that they understand, you know, the similarities and the differences in how they're answered. You're going to assess ambulation, but then you're going to answer each question, whether it be the M1800 or the GG items. The guidance to answer them is a little different. The assessment is the same. So again, you want it to look like the same patient, but make sure you're following that guidance for the correct question, and make sure, you know, you're looking at each one of those to make sure that that clinician understands the guidance and understands the intent of the question. You know, where are you now? You can look at your discharge function score now in IKEY, so you want to do that if you haven't already done it. You know, how are you looking? How do you feel about that? And focus your education based on that. Item by item education, we already talked about that. Make sure, because you know the GG items are so much more granular than the M1800 items. Each GG items tests a different step of ambulation, as an example. So you want to make sure that, you know, each one is answered individually. Focus on what you can control. You know, there are patients that are not going to get better, but you want to make for absolute sure that you're doing everything you can to score those patients accurately in the beginning, put those interventions in place, therapy, whatever it is that's going to help that patient improve. So just, you know, look at your patients, individualize their plan of care, and make sure that you show improvement, if at all possible, on your patients. We already talked about understanding the guidance, and then investment in that education and that OASIS proficiency is going to pay off in the end. You can't QA yourself out of a hole. You have to have proficient clinicians that are answering those OASIS items. Next slide. So that discharge to community post-acute care, switch gears one more time. You want to focus on what it's going to take for you to successfully discharge that patient to the community and they don't die within 31 days. I'm kind of giggling at that because it's not like you can always control that. But what this bottom bullet point here is, if you have this patient on service and they're really hospice appropriate, and this is a hard conversation and I understand that, but you want to make sure that if you have patients that are hospice appropriate, that you're getting them to hospice if at all possible. And it's a conversation, it's a process, and some patients just absolutely refuse, and I understand that, but you want to do your very best to get that patient the appropriate level of care that they need. And if that's hospice, then hopefully you can get them to discharge to hospice when it is appropriate. You want to make sure that you're starting your discharge planning on admission. In the hospital world, we used to say, starts when you're admitting that patient, you're going to talk about discharge. Well, it's almost the same. I know we have a much longer period of care that we're taking care of our patients, but you still want to plant that seed for a successful discharge in the beginning. Next slide. I'm running out of time, so I'm going to talk a little bit faster.
Oh, that's okay.
Sorry. So when you're talking about your monthly and your quarterly focuses, how are you gonna, what's your strategy gonna be? They look, can look very much the same, but you just have to think a little bit different. So when you're talking about monthly, you need to be looking at your outcomes. And if you have the ability to drill down within your software or within an external software company, or however, if you can drill down to your location, to your team, to your clinician, that's going to be your very best bet to get the most accurate data and be able to, do that targeted education and see where your issues are as far as improvement, and as far as what patients are going into the emergency department, the hospital, the observation stays. So try to drill that information down if you have that ability. You want to, look at your QAPI, that needs to be multidisciplinary, and you want to adjust your plans based on what your quality data is. So, come up with a plan, figure out how you're going to improve, and be willing to adjust that as needed. Share the results. I mean, if you have a huge improvement in your hospitalization rate, for instance, or, in your functional scores for a quarter or for a month or for a time period, celebrate that win. Engage your clinicians. They probably have ideas. When I do OASIS education, I usually get ideas from clinicians through feedback. They usually have certain tips that they have or certain strategies they use. When you're talking about quarterly, obviously it needs to be part of your QAPI, that not just the reporting, but how are you getting to those improved scores that you want to get to. Again, make those adjustments based on whatever your results are. And then, invest in your clinicians. Early intervention as far as providing that education. And make sure that, if you identify an issue, you want to make sure that you're getting those clinicians in and make sure they understand the intent of the questions and what it's all about and why, and you'll get a whole lot more cooperation from your clinicians. Next slide. So you want a culture of quality. This is laying your foundation. You want to make sure overall in your agency, and that's a hard thing to build sometimes if you don't have that culture of quality, but you want to make sure that you start on that path for quality to be the way of life in your agency. That's what we strive for. That's what we strive for our patients. They need to, your staff needs to know the why. I say all the time, you know, you tell me to do something, if you don't tell me why I'm doing it, then I'm going to be less likely to do it or to do a great job at it. So if they, you know, how can they contribute? Why are they doing it? That will get you a long way with your clinicians. You want to make sure, like I said earlier, if you're not looking at your reports, you need to be monitoring those closely, your IPRs and your APRs. And I've got a slide here in just the next one or two that's gonna that I'm gonna point that out a little bit. You want also to be able to have real-time data somehow. You know, that may be through your EMR, that may be through some external source, but that data that's being publicly reported is delayed. OASIS competency, we already talked that. I won't mention that anymore. Episode management strategy, focus on those outcomes. You know, focus on outcomes when you're talking about your patients. Are they meeting their outcomes? You know, that should be your focus. And then performance accountability, we talked about that a little bit. You know, if you're drilling down and you're finding an issue with a certain location or a certain clinician or a certain team, whichever, you know, figure out what's going on and then hold that team accountable to improve. Next slide. This is a really busy slide, and the reason it's in here is because I want you to see how busy it is. If you're not monitoring your reports, then you're behind the 8 ball. But what all these little stars on here are a time point that you're either getting a preliminary report, you're getting a final report, or you're getting your preview report, or you're getting a, you know, your preliminary APR report. So I'm going to explain this just really quickly. The kind of orange colored stars, that's your January preliminary and final interim performance report. So those are your interims. You get those for the previous year, and you're going to start getting those so that you can see where you stand. The data you'll notice on that is October 1st through September 30th, and that's of any given year. That's for OASIS because this is ongoing. This is rotating every year. And for your claims and your HCAPs, that's July 1st through June 30th. So that's a full year of data for both of those, and that's reported in January. You get your preliminary, then you get your final. The blue star is your April preliminary and final, or stars, preliminary and final IPRs. So, and you see the dates of data time periods for that. Your OASIS is January 1st through December 31st. Your claims is October 1st through September 30th. Then you have July, the same thing, rolls forward a quarter, the data time period does. Then you have, and that one's red, and then you have the yellow one, which is October. Again, this is every year because since it started and it's going to continue to go. But the other part is your annual performance report. So the green stars are your annual performance report. You're going to get a preview annual performance report. Then you're going to get the preliminary. That gives you time to have an appeal if you don't believe the data is correct. And then you're going to get your final APR, and that comes out in this month, November. And then it's going to be publicly reported in December. So the point with this slide is you kind of have some time points so you kind of know when everything's happening, but this is ongoing every year as long as value-based purchasing keeps going. And it's really important you stay on top of these. So just kind of a summary there and a snapshot. I'm kind of like Sherri. I'm a visual person, so this makes more sense when I can see this lined out like this. Next slide. I think we've got some acronyms because there's, you know, I used to say I hate acronyms. Well, I ought to get used to them because we have a million of them, but this is just giving you some definitions of those acronyms that we use today. Next slide.
All right. I think that's the end of your slides, right, ladies?
Yes, it is. It is. Thank you.
Okay, sure. That was fantastic. Thanks so much for all those great visuals and really breaking things down. We really appreciate it, Sherri and Lisa.
You're welcome.
All right. If you
Absolutely.
would like to learn more about value-based purchasing, I just want to point out that Decision Health has a guide designed to help position your agency for quality success and payment bonuses by delivering best practices for improving all the key items that are used to determine home health value-based purchasing bonuses. And if you are an AHC member, you can get a 20% discount on that book. So follow that link in the handouts if you're interested in digging in a little deeper there. And I also want to remind you that there's still time to take the 2025 AHC member survey. If you're a member of the Association of Home Care Coding and Compliance, we want to know how we can better serve you. So please share your feedback. It's important to help us better gauge your needs and discover what you find most valuable about your AHC membership. Please take the survey at the link in your handouts to help us make AHC everything you need it to be. We hope you enjoyed this episode of AHC Talk. Thanks again, Sherri and Lisa, for all the great information, and thanks to all of you for tuning in. We hope you'll join us again for our December 9 call when we'll be looking at the year 2024 in review. And in the meantime, if you'd like to re-listen to this episode or to a previous one on the go, you can now find AHC Talk on your favorite podcast app. Or you can also listen to the recording and access the handouts on the AHC website. And if you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening, and we'll see you again next month. Take care.